Welcome back to the TV studio for our final session of UEG Week 2022. And I feel like someone has administered propofol because it has been such a painless experience for me over the past 3 days. This is a session where we look back at UEG Week and, of course, today and look forward to 2023. I'm delighted to be joined by Iris Dotan, who is the IBD SciComm member, Albert Nessa, expert in HPB, also on SciComm, Julia Marl, chair of the UEG Scientific Committee, and of course, Elena Cortes-Pinto, UEG president. Julia, we were cautious, excited about the possibility of this hybrid event. How do you feel it's gone?
Well, I'm very glad that it went much better than we ever expected it. I mean, we were still fearing that in September we would need to decide to call off the hybrid meeting and just have a virtual meeting. And I think everybody enjoyed it that much, meeting the colleagues and friends here in the My UEG meeting area, in the industry exhibition. So it was just a great experience, and it was a wonderful stay in Vienna. So I wouldn't want to miss it.
Elena, we'll get into your overall views of UEG Week a little bit later as you say goodbye to our delegates for the last time. But how was today?
Well, today was quite a busy day because I had several different meetings just in the same hours, more or less. I was just running from one place to the other, but still had the opportunity to go to the poster area and to browse through some posters. And there are very interesting posters, in fact.
Nice.
So it was a busy but good day.
You can still see those posters, of course, on the platform, and you can contact the speakers if you didn't get a chance to come here to Vienna. Iris, what did you make of the meeting? A big smile on your face. You must be delighted with how it's gone.
Yeah, actually, it was a fantastic meeting. I think that, of course, the vibes were great. Everyone was very happy to meet each other. Scientifically, it was a fantastic meeting. I think that we had the time of our lives hearing about a lot of new science. I'm talking specifically in IBD, but not only, the lower GI and the rest of the topics. We heard a lot about how to use new molecules, how to apply better our old quote-unquote strategies. And we heard a lot about patient-reported outcomes and issues that are meaningful for patients. So I think this was a fantastic meeting, a lot to rethink, and it's good that we can approach it by the platform.
If you would like to ask any questions of our faculty, we're going to dig into some of the highlights of the day. Please use the Q&A tool. Iris, take me through some of your favorite highlights of the scientific program.
Yeah, so of course, there were so many, and I'm going to do a terrible thing if I'm picking up only a few of them. But I do think there were a few important highlights. I think generally that we are in an era of small molecules where we learn more and more about small molecules. And if to be practical and to name names. So we have, of course, the JAK inhibitors and the more selective JAK inhibitors, the S1P modulators, and the TYK2 small molecules that are coming more strongly into our attention. Yeah. And I think that we started, right, by the best abstract talking about a small molecule. Specifically, it was upadacitinib by Séverine Vermeer. And we ended, actually, on today. We still heard about the importance of upadacitinib, about the potential to increase the dose and to get better responses, on the potential to maintain patients for longer periods of time if we provide higher levels of that specific molecule. But I think that that was a theme throughout the meeting for the different JAK inhibitors, and I wonder if you would agree with me. So I think that definitely that was one important theme about the small molecules and the JAK specifically.
I think we were particularly lucky that most of the phase 3 trials, be it on induction therapy, maintenance therapy, were ready for this meeting, and we got them all hot off the press. So I think all of our clinicians can take back a lot of information to be used in their daily practice, and that was a great pleasure listening. I was just wondering, like, if you think about the JAK inhibitors, and obviously they are very effective, where does the S1P fit in? So do you believe that we will have trials where we will have a direct comparison, or should we go for precision IBD medicine and look for the biomarkers first and get our knowledge there?
So, of course, a fantastic question from the head of our SciComm. So, with the S1Ps were mentioned a lot in that meeting as well, and their efficacy. And we were indeed lucky that everyone made an effort to finish, and we got so many late breakers, even with the pivotal trials and the important post-hoc analysis showing us also for the S1Ps and the TYK2s what can be done with these important molecules. I'm not sure that we're going to see a head-to-head or an industry-driven head-to-head study, but this may be a challenge. So we may see real-world evidence, but this also is not expected soon. So indeed, to the question that you raised and to another topic that was discussed a lot in this meeting, which is personalized medicine and how to do it, whether by transcriptomic analysis of patient samples before we start therapy, whether it is by more clinical biomarkers, whether it is by line of therapy, a lot of post-hoc analysis to look at efficacy of drugs by line of therapy, and I will declare conflict of interest, but today a presentation from our graduate student showing that you can take mucosal biopsies and specifically for the JAK inhibitors and try to apply a JAK inhibitor, but I'm sure this can work for any small molecule on the mucosal sample in order to show whether a specific patient will respond differently to a specific small molecule. So I think for sure we're moving in the way of small molecules. That's first. Important small molecules from various mechanisms of action. And also to look at how we can adjust the right small molecule, and this applies also to biologics, to the right patient.
And are we going to stop maintenance therapy? And do you think we should develop criteria? And will that happen pretty soon? Because now it gets tremendously expensive with all the different MAPs and small molecule inhibitors. And at one point in time, we have to decide when treatment is enough.
So this was also discussed in that meeting quite extensively and was shown. There were a few very nice abstracts trying to look at change of strategy or to change our strategies so that, for instance, we can increase the intervals between anti-TNF injections. Or if we can switch anti-TNFs, how long will that be sustainable? So very nice studies coming from Edinburgh and from the Netherlands about anti-TNFs, both increasing the interval, which is possible. It has a price. In that case, not the economic price so much, but a price in safety and potential immunogenicity. So we should be aware of that. But definitely we're starting to look at the cost effectiveness of the safety outcomes of what will happen if we decrease at first our interval, if we'll decrease the dosages in general of treating patients with the monoclonal antibodies, and then what does that mean for patient safety and for drug sustainability? So this was an important additional highlight.
Yeah, this is something we discussed only a few moments ago, an hour ago on the stage here, talking about, you know, the need to understand when to slow down or reduce treatment when it's not cost effective. It could potentially be toxic and so on. So really interesting, something I hadn't really considered.
And actually, I think so. We discuss a lot now the abstracts and the original studies, but there were fantastic lectures and updates from the best leaders in the field in IBD, talking about JAK inhibition, talking about anti-trafficking, talking about monoclonal antibodies, and every important name, I can't even start naming them because really everyone made an effort to update us on really what is most recently important and how we can use better implement ourselves, because we asked that, but that was a lot also in the abstracts coming from the industry and the investigators, trying to look at patient-reported outcomes and meaningful outcomes for patients. For instance, focusing on stool frequency, on rectal bleeding in ulcerative colitis specifically. This was highlighted a lot, specifically with the IL-23 inhibitors, for instance. The urgency for itself now becomes an important patient-reported outcome. And I think that this is important, and it's also important for patients to know that we use a lot on outcomes that we believe that are important, but also that they believe that are important, including psychology, nutrition, and whatever else patients are interested in.
Albrecht, you've been on the scientific committee now for a year and a half. How have you found it? Any stories to tell?
Well, it's been an exciting journey. Being on the scientific community has been a great experience for me. It's a lot of work. It's a lot of daily exchange of emails. It's Zoom conferences, but it's also meeting in person regularly. And I really enjoyed those meetings, working together as a group for the different areas, HPB, upper, lower GI, but also meeting up in the evening and socialize with all those specialists has been really great.
Take me through your highlights from UEG Week 2022, please.
Well, actually, one of the major goals of the scientific committee is, first of all, encouraging young scientists to present their work, but also encourage clinicians to understand what scientists do. So what we call like translational sessions.
Yeah.
And to bridge this gap between science, basic science, and clinical daily practice. And there have been a number of very exciting presentations. And again, it's hard to pick one, but I think one of the major problems that we are dealing with now for many decades is how we can block proliferating tumor cells efficiently. And one of the holy grails have been KRAS. KRAS is an oncogene. And once you see a mutation in KRAS, cells start to proliferate. And nobody has been able to actually pharmaceutically target KRAS. And we have just seen a specific KRAS inhibitor being approved this year, beginning of this year, not for GI cancers, but for lung cancer. And it will be very interesting to see whether those compounds will work also in GI cancers. And there has been a wonderful presentation with outstanding scientists explaining those compounds that are in the pipeline and that will come up in the next couple of days and years for our patients. And I think that is crucial, that doctors understand what's going on. How can we also contribute to the development of those compounds?
Do you remember the name of that session, when it was?
That was a session actually I chaired yesterday morning very early, 8 o'clock, and it was targeting growth signaling in cancer.
Okay, if you want to watch back any of the sessions, you can do so on the platform until November 17th. You'll find them then in the UEG library. Any other highlights, Albrecht?
Well, apart from the oncology, well, HPB, one of the major diseases is acute pancreatitis. There's a major study that has been published just weeks ago, the Waterfall trial. We treat acute pancreatitis early on by administering fluids. And we've never been quite sure how much fluid we should add to patients. And this is a randomized, large trial that has been conducted by Enrique de Madeira, 18 centers, European-wide, but also US. And they enrolled more than 200 patients, randomizing them to aggressive fluid resuscitation and moderate fluid resuscitation. And what they found, and this is actually contrary a little bit that what we thought, is that moderate fluid resuscitation is more beneficial than the aggressive fluid resuscitation.
Right. Do you know any reason, any understanding of why?
Mechanistically, it's difficult to explain it like in one sentence. But what they found, and actually this trial was interrupted early because the trial investigators saw that they had to interrupt it because it was the aggressive regimen was too much for the patients. But these patients with aggressive fluid therapy ended up in intensive care more often. They had fluid overload, and the hospital stay was prolonged. So clear indications that we should have moderate fluid resuscitation I think this is a major finding in the field of acute pancreatitis.
Yeah.
Oh, I'd just like to comment on that because it's interesting. When I started the GI and the intensive care unit, we used to completely overload the patients with fluids. We sometimes give them 6 liters a day of fluids.
Wow.
And then increase, and then in time we have been decreasing. And in fact, sometimes I think they were kind of drowned in liquids. So it's very interesting that we're able to clearly demonstrate the benefit of moderate instead of very aggressive fluid overload. So I think that's an important information for clinical practice in general, and because this may be the difference between living or not if a patient has a very strong overload of fluids. Yeah.
And it's a New England Journal publication
Absolutely.
3 weeks back.
Yeah.
So it's something
I
we
get
need to discuss here, and this is why we come here to discuss it. But it also shows that it's not always the small molecule which is needed to actually make a change. So in this case, the magic bullet is Ringer's lactate, a drug known for centuries.
I get the sense that a lot of things aligned in advance of today and the last couple of days just to bring all of this science together. Presumably that doesn't happen every year, or do you have some religious connections that you can...
We definitely do have some religious connections, and it's obviously to whom.
Yeah.
It's all the societies who actually contribute to UEG. And each of those societies thrive to bring the best abstracts and results to the week. And therefore, we pray for it, but we do not have a lot of doubt that it won't work out.
Right. Albrecht, any other highlights from UEG Week 2022?
Well, talking about cancer, GI cancers, immunotherapies has been a major topic, not just here, but overall. And there have been a couple of very interesting sessions on immunotherapies, explaining the mechanism of immunotherapy. So taking off the brake of the tumor immune system, activate lymphocytes to kill tumor cells. These therapies are great. Still, they have side effects. And what we don't quite understand so far is which patients actually benefit from the therapy and which don't. There has been a great oral presentation this morning about hepatocellular cancer patients. Recently, there has been a new immune therapy being approved for these patients, but still the inclusion criteria were very strict. And the Japanese group that presented their work looked at 200 patients, again, 2 groups, each about 100 patients, and they widened the selection criteria, and they looked for markers which patients would benefit from this immune therapy. And they had very interesting results. For instance, there is a ratio of neutrophils versus lymphocytes, and if the lymphocytes are high and the neutrophils are low, those patients are more likely to benefit from the therapy. And I think this is an important concept that we should follow over the next years to, again, expensive therapies, but also therapies with side effects, that we should try to tailor these therapies to those patients that benefit most.
It seems to me that not just in the disciplines of GI or digestive health, understanding our immune system better, figuring out how to control it seems to be the key to unlocking a lot of therapies for patients.
Absolutely.
Okay, Albert, any other highlights? That's it?
Many more, but...
Exactly, yeah, well, we could be here all day. So, Julia, looking back on UEG Week 2022, any learnings from what's happened over the last 3 days?
Yeah, I think one of the learnings is that we have to, as we don't have any printed program yet, we have to make sure that people understand what to expect under a certain heading.
Yeah.
So the SciComm put a lot of thought in excellent sessions like the anniversary session yesterday, and also the plenary. And the moment you have a mixed bag of things inside a session, people usually, if they just follow a certain path, so like the IBD path or the upper or lower GI or HBP path, they miss those sessions. And I think that is something we have to advertise next year, and say, look, that's going to be a real interesting, hot topic thing. You might not recognize that from the heading, but have a look inside.
Yeah.
And that is something which we really should change. Then again, I mean, what we also have learned is that probably Sunday night should start a little bit earlier. And we should not make our delegates, our faculty and our visitors work too hard on a Sunday. We are working hard the whole week, so give them some time off. So that is something. Then I also learned that most likely we need more live endoscopy. It's something which is really good, and the quality was excellent, and also it relates to our daily clinical practice. So
And you had queues, right? You had people queuing up to do it. So
queues. So thanks to ESGE and Eskena for actually helping that and setting that up. It was really a huge contribution to the week.
yeah.
So that is something we should definitely keep in mind. And the abstract-driven sessions were excellent, and I really enjoyed the discussion time. So there were intense discussion, and also it really fostered collaboration. So that is something which we definitely would want to keep. So some learning experiences, I'm pretty satisfied.
Yeah, we were having a conversation earlier and talking about the fact that COVID meant that sometimes young GIs weren't getting the access to do operations, do endoscopies in the theater. They were reassigned to COVID wards, and they just haven't been getting that hands-on experience. And I think that's why something like that is so important at UEG, and probably unsurprising to see those queues and that big demand. So it's great that they had the opportunity to do it here, because they're not getting that access in their own practices, it seems. Elena, this is your first UEG Week 2022 as the first female president. You must be extraordinarily proud of your achievement. It's been absolutely buzzing here in Vienna for the last 3 days. Fantastic party last night. How do you feel this meeting has gone, and has it met your expectations?
Well, Jonathan, I think this has been an outstanding event, and it met all my expectations, and more than my expectations, as also Julia mentioned. And in fact, I have been congratulated by so many people, although in fact, I think it's Julia Miley and the scientific committee that has to be congratulated, because they made a program. But besides being a very good scientific program, I think it was also socially a very good event, because I think people had the opportunity to talk, had the opportunity to see them again. I think the way it was put, it was very good for people to be able to be together. So I'm really proud and happy. But what I also want to do is to thank all our industry partners, all the staff, all the suppliers, and everyone who has really been involved in doing the event. But particularly our office, because our office has this way of putting everything run smoothly, so that it looks that this has been easy to do and to plan. But I really think it was an outstanding event. I'm very, very happy and very proud.
Well, let me echo those thoughts, Elena. They are a fantastic team to work with, and thank you to the UEG team for having me again this year. I always enjoy visiting. Thank you all for joining me for this final session. Did you have something you wanted to say?
Yeah. A couple of things I'd like to add, because I mean, I have to give you some outlook for next year, or I mean, we want to invite you to next year, and I have to tease you somehow. So I think one fact we learned is that we should really foster more interdisciplinarity and also interprofessional learning. So we want to drag in our nurses much more and have our hands-on training together and really foster that, because there is no hierarchy in medicine. We rely on each other, and it's important that we train together, we educate each other together for the benefit of our patient and also for our fun. I also want to say that this TV studio and the formats in here, and looking beyond gastroenterology meeting society, as we call it, digging deeper, is something we really would like to continue, and I'm sure there are many more topics we would like to look at. And we also want to involve our patients, because that is something which we have learned from the IBD community and also from the oncological patients, but I think they should be involved in all our efforts, because those are the ones we serve. And we also want to involve our surgeons. So we need a surgical hands-on training area, because GI medicine is no longer endoscopy, and endoscopy crosses boundaries. Like, we do make perforations. Mostly we try to fix them ourselves, but sometimes we do miserably fail. So, and either we're gonna not waste a disaster, or we're gonna try to do some training with them. So we will have joint trainings with the surgical community, and I think that's an asset for next year.
Yeah, and there's been lots of conversations echoing those exact sentiments, Julia. Thanks very much. So thank you very much for joining us here at UEG Week 2022, whether you are here in Vienna or at home. We hope to see you here next year in UEG 2022, where we'll be going to Copenhagen. If you want to watch back any of our sessions, you can do so on the platform until November 17th. Do register for UEG newsletters, follow us on social media, and connect with faculty using the MyConnect platform. In the meantime, we hope you have a fantastic year. We hope you get a great amount from UEG Week 2022, and you hope to take advantage of all those opportunities we've discussed over the past couple of days. Have a great evening, and goodbye. Thanks, folks.
Thank you.
Thank you.
Thanks.